Hello class, we're going to continue now with the parathyroid glands, and just a quick anatomy and physiology review is, remember, they are located within the back surface of the thyroid glands. They're basically four small glands that are located close or within the back surface of the thyroid gland. Okay, they're actually embedded in the thyroid, and the chief cells produce and secrete PTH, and PTH stands for parathyroid hormone. So this is kind of an easy gland because there's only one hormone, and it's a hormone that names the gland itself, parathyroid hormone. Okay, but this is a very important hormone. Okay, it actually regulates calcium and phosphorus metabolism by acting on the bones, in the kidneys, and in the intestinal tract. That's the systems in which it controls our calcium and phosphorus levels. And please think back, what I told you earlier was there is that inverse relationship between calcium and phosphorus, where if calcium is up, phosphorus will be down, and when phosphorus is up, calcium will be down. And that's really important to remind yourself, so that when we discuss the abnormalities of the secretion of PTH in regards to too much or not enough, and we talk about hyperparathyroidism and hypoparathyroidism, it'll make sense why calcium levels are high or low, or phosphorus levels are high or low within those disorders. Remember, when we talk about calcium, really the main storage of calcium is bone, okay? And PTH will increase bone resorption. And what bone resorption is, that's the ability of this hormone to actually release calcium from the bone to hopefully increase calcium levels, okay? And again, I just want to remind you that PTH kind of works in collaboration with calcitonin. I didn't talk much about calcitonin in regards to the thyroid gland, but that is another thyroid hormone that is secreted. And you might want to think, okay, why do we have two hormones that control our calcium levels? And that's a great question. And what I want you to do is to understand why. Because when it is kind of sensed that that our calcium levels are too low, then PTH will be secreted from the parathyroid glands, okay? And so with that being secreted, it will increase bone resorption. It'll say, hey, calcium levels are low, let's get more calcium into the blood. Where am I going to get that calcium from? Oh, let's get it from the bone. That is the main storage of calcium. So it causes the breakdown of our bones and causes the release of calcium in the blood to thus increase calcium levels. But when the body senses that calcium levels are getting too high, that's when calcitonin is excreted, or secreted from the thyroid, because it will stimulate osteoblasts, calcium from the blood, and will start to build bone. So it'll take the calcium out of the blood, inhibit those osteoclasts, and will thus decrease blood calcium. So that will, and then you'll turn off that calcitonin. And then the opposite is, if, like I said before, calcium levels are too low, then PTH is secreted to help bring back calcium levels up, and that stimulates the osteoclasts. Remember, those are the ones that actually promote breakdown of bone, and so it will inhibit osteoblasts, which build up the bone, and it'll take that calcium from the bone and cause that calcium level to rise. And then, of course, when it does, at the accepted level, then PTH is turned off. So that's how it all works. And then let me just bring the slide down again. Within the kidneys, PTH activates vitamin D, which increases the absorption of calcium and phosphorus from the intestines. And in the kidney, tubules, PTH allows calcium to be reabsorbed and put back into the blood. And this is why your patients who have chronic renal failure with their kidneys not functioning correctly, this is why PTH will not have an effect, at least a positive effect, and that's why our patients with chronic renal failure have so many problems with phosphorus levels and calcium levels, and we'll talk about that when we get to the renal system. But I kind of wanted to remind you that this is why, because without normal functioning kidneys, it cannot go through this process of increasing the absorption of calcium and phosphorus, okay? And this is why our patients with renal failure have problems with these two particular minerals, okay? So the kidney tubules, along with when PTH is secreted, allows calcium to be reabsorbed and to be put back into the blood. And remember, serum calcium controls how much PTH is secreted. So secretion is decreased when calcium levels are high, and secretion is increased when calcium levels are low. So really, PTH basically is responsible for increasing calcium levels, where calcitonin, the hormone from the thyroid, is responsible for bringing down calcium levels, okay? And they do that through the bone. And remember, the normal lab value of a calcium level is 9 to 11 milligrams per deciliter, okay? So I hope that all makes sense to you. Please read it over again or listen to me again so you really understand the connection between PTH and calcitonin and how they both work in unison to help either increase or decrease calcium levels, because PTH can only increase it and calcitonin can only decrease it. So each one of those cannot do both. So that's why we need each of their proper secretion to keep our calcium levels within normal range, okay? So that is how PTH works with the kidneys, the bone, and the intestines. Remember, serum phosphorus also affects PTH secretion, because remember, again, calcium and phosphates are inverse. An example is when calcium levels are up, phosphorus will be down, and vice versa. And calcium fluxes in and out of the bone to maintain serum levels. So now it makes sense when we talk about the oversecretion of PTH or the undersecretion of PTH, we're going to definitely have serious calcium and phosphorus problems, okay? All right, and this, again, is just that picture. I think this picture is in your book. And I just want to kind of show you again how parathyroid hormone acts on receptors in bone, kidney, and intestines, and that through extracellular fluid in the blood, plasma, and interstitial fluid, calcium is increased. So that's the role of PTH, is to increase blood calcium. And they maintain that through feedback inhibition will reduce parathyroid hormone secretions when calcium levels are normal. So that is a very nice diagram of the physiological actions of parathyroid hormone. Okay? And again, with this and any other endocrine problem, again, one area that we really look at is our patient's nutritional history. We look at their GI history, because so many patients that might have calcium problems will definitely have their GI tract affected. Nausea and vomiting, abdominal pain. Then we look at things like excessive thirst, and with adrenal hypofunction, we might have a person state that, hey, I really have this incredible craving for salt. And the reason is because those patients with adrenal insufficiency have low sodium levels. So to detect and bring more sodium into the body, a person will start to have salt cravings. And again, all these thyroid problems may be attributed to rapid changes in weight, maybe dietary deficiencies. Maybe a person isn't taking enough protein or iodine in to make actually thyroid hormones. We look at a lot of family history, thyroid problems, even current health problems, what's going on with you now, gradual symptoms or sudden onset, what kind of problems and treatments did you have in the past, and what are your current symptoms that affect activities of daily living. What are your energy levels? That can occur with many endocrine problems, particularly thyroid and adrenals. And then we look at elimination along with urination and as well as bowel function. And of course, sexual or reproductive functions, changes in menstrual patterns, impotence, or maybe even changes in libido, increased libido or decreased libido. And just looking at the person physically, do we see any abnormal or grotesque features that a patient may start to develop? And looking at hair texture and distribution, voice quality, body proportions, and secondary sex characteristics. Okay, so those are just a few of the ways in which your healthcare providers may do a real thorough assessment on these patients to determine maybe what is a potential endocrine disorder occurring, so we can kind of hone in on that and maybe do diagnostics to determine if that is actually the problem that the patient is experiencing. Okay? All right, so let's talk about the problems now. Okay? The first one we're going to talk about, which is much more common than hypoparathyroidism, we're going to talk about hyperparathyroidism. Okay? And what we see occurring with this is an excessive production of parathyroid hormones by the parathyroid glands. Okay? And of course, remember how we talked about primary, secondary, and tertiary. With primary hyperparathyroidism, there's probably some hyperplasia or tumor in one of the parathyroid glands, so you have an increase the absorption of calcium in the GI tract. Okay, this condition is much more common in women, about 2 times more common than men, so we see it more in women. If the patient has secondary hyperparathyroidism, may be due to a gland enlargement due to chronic hypocalcemia in the presence of elevated PTH, okay? And then sometimes tertiary glands are enlarged and do not respond to changes in serum calcium levels, such as associated with chronic renal failure. And sometimes our patients with chronic renal failure do develop hyperparathyroidism, okay? And with hyperparathyroidism, with the excessive production of parathyroid glands, we have increased resorption of calcium and an increased excretion of phosphate levels. So what this will lead to is hypercalcemia and hypophosphatemia. So we've got decreased osteoblastic or bone production and increased osteoclastic. So what's happening is we have increased bone destruction, pulling calcium from the bone, thus increasing calcium levels. Okay, and kidneys start to excrete bicarbonate and decrease acid excretion. Okay, and because this excessive PTH is constantly pulling calcium from the bone, now we're reducing bone density, and calcium can actually deposit in the soft tissues. And because the kidneys are decreasing acid, by excretion, it can lead to metabolic acidosis and hyperkalemia. Okay, and this problem with increased calcium, with this calcium depositing in the soft tissues, a person would be more prone to renal calculi, altered neural function with muscular weakness, altered GI tract with constipation, abdominal pain, more prone to peptic ulcer disease, anorexia, and an altered cardiovascular system. Go back to think about those calcium ions we talked about in cardiac and how they were responsible for the normal contraction of the heart muscle. So now we've got a bunch of calcium on board, and this could definitely cause some arrhythmias and irregularities or very significant changes in the EKG patterns, okay? We know that it may occur because one or more of the parathyroid glands are not responding to the normal feedback. And again, you know, you might think, oh, it's only calcium, but really calcium is a very important electrolyte because it really does maintain normal functions of all these systems. And when we have high calcium levels, which is what your labs would show, and we'd have increased PTH levels, decreased phosphate. Also, we'd see definite and significant bone changes in the x-rays and CT scans. It's going to affect all systems, okay? Most of the hyperparathyroidism that we are talking about is probably primary hyperparathyroidism, where it's caused by an enlargement of one or more of the parathyroid glands. It is a fairly common disorder. It can affect about 1 in 1,000 people. And as I said before, these high calcium levels really do affect several body systems. As you can see from the PowerPoint slide, the GI tract causing hyperacidity. This is why they're prone to ulcers. The renal system can cause polyuria, increased chance of renal calculi. As nurses, we might suspect our patients having renal calculi, so it's necessary that if we think they may have acquired a kidney stone, that we would save the urine and definitely strain it and then send it down for analysis. Sometimes your patients can be very symptomatic when they have a renal stone as it moves down the ureters. Cardiovascular system, shortened QT intervals, increased contractility, okay? Neurologically, we see muscle weakness, extreme fatigue, obviously it makes sense with the bones that these people would have bone pain, osteoporosis resulting in fractures. So right here we are really seeing a safety issue with these patients because we don't want them falling. We want to be careful how we move them in bed because, man, they could fall and, wow, just one fall could cause them to have some kind of pathological fracture. Sensory, confusion, drowsiness, depression, or lethargy. Some of these patients really start to exhibit emotional irritability due to the increased concentrations of calcium in the brain, okay? They become very apathetic, fatigue, muscular weakness, nausea and vomiting, constipation. We've got them on a cardiac monitor to really assess for any cardiac dysrhythmias or even a possible cardiac arrest if that calcium level gets too high. So not only are we worried about the psychosocial state of psychosis, confusion, coma, and death, but we're also concerned about the cardiovascular state where the patients can actually have a cardiac arrest due to the high calcium levels, okay? So what are we going to do to treat this? And that's a great question. Obviously our goal is to bring down those calcium levels. One thing that we can do, and sometimes we see different varying degrees of, this should be hyperparathyroidism, sorry, not hyperthyroidism. You know, a lot of times these patients with hyperparathyroidism, if it's mild hypercalcemia, the person is really urged to drink fluids and keep active. Avoid immobilization because you want to keep these people mobile because it's less likely. It becomes very resistant to pulling that calcium from the bones. We might also give thiazide diuretics, large doses of vitamin A and D, and antacids containing calcium and calcium supplements. If it's very severe, they're going to definitely put the patient in the hospital because now we want to give them IV fluids such as normal saline and really give them copious amounts, obviously, if their other health conditions allow it, to hopefully bring down these calcium levels. Because if they're high enough, just like I said before, we're worried about the cardiac status and, you know, kidney stones and things like that. We might also give meds to inhibit bone resorption and reduce hypercalcemia, such as Iridia and Fosamax, Zometa. Those are short-term treatments, but they will help improve the density and help with the bone pain that the patient is experiencing. Monitor cardiac status. Be careful when we're trying to bring these calcium levels down that we don't bring it down too fast, because then the patient can develop signs and symptoms of tetany, such as tingling and numbness in the muscles. Again, keeping the patient safe from pathological fractures, proper lifting, and assisting when ambulating. Okay. These are other continued treatments. Encourage weight bearing, low calcium and diet. Teach to report any GI symptoms. Watch that GI tract. Sometimes they can really start to develop ulcers and things like that. Because calcium levels are high, phosphate levels are low, so we want to give IV phosphates. And calcitonin is another way in which we can hopefully bring down those calcium levels. There's a form of calcitonin from salmon available as a nasal spray or either IM or sub-Q injections, and decreasing the levels of calcium by inhibiting bone resorption and increasing calcium excretion by the kidneys. So with that needed, patients need to have a fairly decent kidney function. That's what we need to do. If these interventions really do not help bring calcium levels down, sometimes it's a matter of removing the parathyroid glands. Sometimes these calcium levels can get very high that it might be necessary to dialyze the patient, okay? It just all depends on how high these calcium levels get as to whether or not we're going to treat these patients on an outpatient basis or put them in the hospital so we can keep a really closer eye on them. Obviously, with hyperparathyroidism, serum calcium levels are increased, serum phosphorus levels are decreased, serum alkaline phosphatase may be increased, and bone x-rays may show bone reabsorption or fractures, and they may also do imaging of the kidneys or ureters to show any calcifications or obstructions with these particular stones. They might do a DEXA scan, and what that is they're done for people that might have severe osteoporosis. They're looking at bone mineral density, and these are really very high specific testing to really look at the bone density of an individual. A DEXA test may be done to really look at their bone integrity. Okay, so that's hyperparathyroidism. Okay, we are very, very concerned about these high calcium levels. Again, they will also need dietary teaching about foods that are high in calcium, and about foods that are high in calcium because they wouldn't want to be eating those. So they're going to need foods that are low in calcium and high in phosphorus, okay? Encouraging mobility, and again, a lot of fluids to hopefully secrete the calcium and prevent the patient from developing renal calculi, okay? So that would be hyperparathyroidism, okay? All right, the next thing we're going to talk about is hypoparathyroidism, okay? Now this disorder is much rarer, okay? It's a lack of PTH or effectiveness on target tissue, and just the opposite is occurring. Hypocalcemia, and these are the causes. Iatrogenic hypoparathyroidism, idiopathic hypothyroidism, or hypermagnesium malabsorption syndrome, where osteoporosis may occur. Remember, we need calcium for bones, teeth, blood clotting, normal heart function, and hormone secretion, okay? And why does this happen? And that's a great question. What we see happening here with hypoparathyroidism is a deficiency of parathyroid hormone that causes abnormal metabolism of calcium and phosphorus, thus making your patient hypocalcemic, okay? And what happens is blood calcium levels will fall and phosphorus levels rise. And these calcium levels can get as low as, below 6.5. And what you might see on your patient manifest is signs of tetany, okay? And the most common cause is any injury to the parathyroid glands during head and neck surgery, and rarely a side effect of radioactive iodine treatment for hyperthyroidism may occur. But PTH secretion may be impaired when blood levels of magnesium are low or when blood pH is too high, if the patient develops like a metabolic alkalosis. Those aren't as common, but those could be causes. So all things will be looked at if we suspect that your patient is hypoparathyroid, okay? Risk factors would be any recent thyroid or neck surgery, family history, or history of certain autoimmune endocrine disorders, maybe such as Addison's, okay? And again, all the signs and symptoms of somebody who has a low calcium level would be, tingling of the lips, hands, and feet, muscle cramps, pain in the face, legs, and feet, abdominal pain, dry hair, brittle nails, dry scaly skin, even cataracts or weakened tooth enamel in children, and muscle spasms called tetania can lead to spasms of the larynx with breathing difficulties, and that is our concern with somebody with low calcium levels. Abdominal and skeletal muscle cramping, which could lead to eventually convulsions or seizures, okay? And tetany could occur in the bronchioles, causing a bronchial spasm, laryngeal spasm, or a carpopedal spasm. And what that is a flexion of elbows and wrists and extension of the carpophalangeal joints. And remember, I discussed Trousseau's sign and Schroff's stick sign. Those are signs of low calcium or tetany. And Trousseau's sign is when you have a positive carpopedal spasm. And what that is you put on a blood pressure cuff and you occlude the blood flow to the arm for about 3 minutes, and what happens is the arm starts to spasm, it kind of turns in, and that's what a Trousseau sign is. Now, Cho's stick sign is usually positive when you sharply tap over the facial nerves, causing the mouth, the nose, or the eye to actually twitch. So those are signs that we can kind of test for tetany, okay? Other symptoms a person may have are painful menstruation, hand or foot spasms, decreased consciousness, delayed or absent tooth formation. So of course they're going to have low calcium levels, elevated serum phosphorate, and definitely decreased serum parathyroid level hormones, okay? Of course, being that these levels are getting so very, very low, we're going to have these patients on a heart monitor to assess for any abnormal heart rhythms, and we are definitely going to need calcium resorption weight-bearing exercise, use of weights to make the bones more dense, vitamin D, watching for those signs of tetany, and diagnostics to determine hypoparathyroidism, ECG, blood test, CT scan. Teaching patient about increasing calcium levels by diet, so foods that are high in calcium and low in phosphorus, and patients also at that time should wear a MedAlert bracelet, okay? That's basically hypoparathyroidism, okay? We might give IV calcium gluconate, supplemental calcium, and vitamin D therapy, okay? And, this is nothing to kind of ignore, because a person could actually face death if calcium levels get too low, okay? Our goal is to get these calcium levels up, and the way that we could do that, especially if they're hospitalized, we may want to get them quickly, especially if they're extremely low, is by giving IV calcium gluconate or calcium phosphate. That's hypoparathyroidism, okay? So hopefully that makes sense, and you look over this and you kind of understand, where the parathyroid hormones are at, or the parathyroid glands are at, what hormone is secreted from these glands, and what does that PTH do in regards to working with the bone, the kidneys, and the intestines, okay, in the control of maintaining a normal calcium and phosphorus level, okay? So thank you for your attention, and let me know if you have any questions. Thank you.